All right. Hello, everyone, and good morning. Today is the last class of this HRCT course. I'll end this course by today's session, and we will discussing in today's course about pulmonary cysts, differentiate different type of cystic lesions, and then we will diagnose the most common cystic diseases. Diagnose and discuss the most common disease, cystic lung diseases. We will learn how to classify emphysema and bronchiectasis, and then we will learn how to write a structured HRCT report. So without further ado, let's get started. All right, before any reporting, you have to first know that if the cyst is normal or always abnormal, right? Sometimes cysts can be seen as an incidental finding, and in those cases, you don't need to worry about, and you can label the cyst as the incidental findings if there is number is less than 4 and usually seen in the patients 40 or 40 above, right? So the rule of 4 is usually followed in those patients. That is rule of 4 and 40. More than 4 cysts, no more than 4 cysts in an individual 40 or above, right? So in those patients, for less than 4 cysts are normal, and you are not going to worry about and start diagnosing those cysts as some kind of pathology and label it as a some disease pattern. So ignore those cysts in the those in this setting. Now discuss what basically is the cyst is. Cyst is basically a round oval shaped lucency, which is usually filled with the air, right? It's a low attenuation structure. Usually has a thin wall, less than 2 mm, right? And usually margins are very much well defined. And the adjacent lung parenchyma is normally not is the normal. It is surrounded by the lung parenchyma, right? And you need to differentiate when to label the cyst as a cyst and not to confuse it with cavity, honeycombing, and emphysema. We'll be discussing all these in detail in the coming slides. Now, first, let's discuss what is the cyst. Cyst, previously we discussed, has usually thin walls. This point differentiates the cyst from cavity, which usually has very thick walls, right? And it also walls are kind of irregular. Honeycombing is these cysts are very small, usually seen in the as a pattern of layering, right? 3 to 10 in size or variable, and usually seen in the setting of interstitial lung diseases like with significant fibrosis, architectural distortion, right? So those are honeycombing. We'll discuss these in very much detail in the previous class. So I'll not go into detail in this session. And next is emphysema. You have to differentiate a cyst from the emphysema, which usually has no walls. So if the wall is seen, thin wall is seen, it's usually a cyst. If no circumferential thin wall is seen, then it's probably emphysema. And the cavity has thick, irregular walls. Next comes the honeycombing, in which we discussed that it shows layered pattern of distribution and usually subpleural in locations. And emphysema has no walls. Now, this is basically a cyst. It has very thin walls, right? And previously we discussed that its wall size is 2 mm, right? Over here we mentioned it. So please notice that its size is very much less. It's approximately 1 mm. However, in the cavity, you will see that the size is very much large, right? It is very much large in size. Now, next is emphysematous bulla. This is usually a bulla which is usually seen after some coalescence of the disease, and its size is usually seen more than 1 centimeter, can be up to 10 centimeter in size, right? And next is nematocele, which is usually seen in the settings of like infection, it usually resolves in the follow-ups HRCT. You won't get to see this nematocele in this location when the consolidation will resolve. So it is usually seen adjacent to consolidation and infection this pattern of lung diseases, right? And this is the emphysematous bulla, this is cavity, and this was cyst. Now this is again the true cyst which I was talking about, in which you can see circumferential walls can be appreciated, and this is emphysema in which no walls can be seen. And in fact, in center there is a hyper dense structure, which is also a clue that it is emphysema and it is not a cyst, right? And the central dot can be seen. And this is again is honeycombing, and this is bronchiectasis, which usually seems to be a cyst. In some cases, you have to rule out this by scrolling the disease up and down in the axial slices. This cystic bronchiectasis is going to run into each other, right? And you will see as a pattern of rods or like some, these all should be intercommunicating. So it is a bronchiectasis. However, cysts won't be intercommunicating with each other in the slices up and down. Now, next you have to see and look for some nodules, or you have to look for ground glass pasties. Those two etiologies are going to classify our disease into two patterns. First is LCH and lip, usually seen when there is cyst in addition to nodules. If there is cyst in addition to ground glass opacity or haze, then the differentials would be lip and dip. And if no nodule or ground glass opacity is seen, then the differential would be very much easy. It would be BHD, LAM, LCH, and lip. Now, let's discuss over here. Here you can see there are multiple small cysts, and you can also see nodules. So it is a case of LCH. Now, this is the case of lip in which you can see cyst in addition to ground glass haze. Here you could see nodules with cyst. Here you can see ground glass haze with cyst formation. And here you can see neither the nodules nor the cyst. So it is a typical case of lamb, right? In lamb, you won't see anything. It's usually seen in settings of in females, reproductive age females, right? And lip and dip, it has strong association with connective tissue diseases, and LCH is usually has strong association with smoking. Next, you have to see this. These are different type of cysts. Here you can see these are have thin walls and very much round. So this is again case of lamb. Here you can see that the cysts have lenticular shape, and they are usually periseptal. So it is a Bird-Hogg-Dubinson syndrome, right? These are irregular, bizarre shaped cysts. So it is a case of LCH. Next is usually vascular indentation within the cyst can be seen. So it is a case of lip. And next is nodules giving Cheerio sign. So it is seen in the settings of LCH and METS. And here you can see the cysts are seen with the ground glass opacity. Previously, we discussed that it is seen in the case settings of lip or dip. So lip or dip, ground glass opacity assist with nodules in the settings of LCH. Cyst with vascular indentation again with lip. Bizarre shaped cyst LCH, lenticular shaped cyst Bird-Hogg syndrome BHD, and if the thin wall cyst just and no ground glass opacity or nodule seen, then it is lamb. Diffuse cystic lung diseases. Now I'll be discussing the approach for diagnosing and differentiating different type of cystic lung diseases. If the cysts are uniform throughout the lung, then they are lamb. Then the disease is lamb, and previously discussed with nodules and bizarre shapes LCH, basal cysts seen in the setting of BHD, and lip is has previously discussed that it's autoimmune disease, and GG was usually seen. So you have to like report every finding in your case and then come to the diagnosis. First, you have to describe the findings and your pattern of distribution, wall thickness, associated finding if the nodules or ground glass opacity can be seen. Walk through the whole scan in the soft tissue window and in the bone window. Look at all the bones in the bone window and the soft tissue window. Look all at the esophagus if it's any dilatation. Look for the mediastinal lymph nodes. Look out for any ancillary findings, right? Effusion and callus effusion and all those things in the soft tissue mediastinal window. So it is very much important to see your whole scan in all those windows. Now next is lamp, in which you can see that there are multiple like symmetrical, a kind of equal size, not much variable size shear cysts can be seen and throughout the lung parenchyma, and they are not sparing any periphery and CPN, right? However, in LCH, the cyst would be very much bizarre shaped, right? They would be bizarre shaped and like no, they won't be symmetrical rounded. In fact, they would be very much like bizarre in size and shape. And next, and they would be sparing the lower lobes, right? You cannot see any cysts in the lower lobes. Next comes BHD, which has strong lower lobe distribution, right? Here, this is BHD. Now, first, let's discuss what is basically LAM. In lamb, you will see the thin wall cyst, uniform size, with normal intervening lung parenchyma. Usually seen in women, lamb has strong, like when there, you can remember that W and inverted W is basically the M, and this is in M. So this is the same thing. So can like make you remember that lamb is usually seen in women, female. And they are usually thin walled cysts, right? Uniform size with a normal intervening parenchyma. And you can see, could see that in some cases there could be tuberous sclerosis association, and sometimes pneumothorax can also be seen. The fold is the diffuse cyst, including the lung bases, usually seen in lung. Now let's discuss all these cases. This is a lung window of HRCT, a multiple cyst with the thin walls seen in bilateral lung parenchyma in the throughout the lung parenchyma. It is not showing any like zonal predict. It won't be showing any zonal predilection. Now here again, the cyst can be seen. And now here again, these are all the cysts. These are all the cysts, right? So, and they have very much like thin walls. If you zoom in and out, you will get to see walls in adjacent to it, and they're not much variable in size. Like the sizes are like small, all the cysts will be small. If the site is moderate, all the cysts will be moderate, right? And so that's the setting usually seen in the case of lamb. Next is this again a few more cases of lamb. Here you can see again the variable size is cyst. Sorry, it is same size cyst throughout the bilateral lung parenchyma involving the bases, apices as well as CP angles, right? So this is again a very much typical case of lamb. These are all cases of lamb. Here you can see that there is some effusion within noted within it, and this effusion, if there's aspirated, mostly seen as a callus effusion, usually again seen in the settings of lamb, where you can see multiple cysts can be seen. So if it's a female and symmetrical cyst in bilateral lung parenchyma and with some effusion, so it's our probable case of lamb. Now next, you are being shown the slide in which you can see that we have been given only the soft tissue window of the abdomen. And here you can see that lamb are usually Previously I discussed that lamb has a strong association with tuberous sclerosis. So here you can see that multiple renal lymph angiomyolipomas can be seen in association with lamb. So these are the cases, limited sections of the kidney, and in which case you can see fatty attenuation lesion in the right region of the kidney, in the right kidney adjacent, and it's kind of replacing the renal parenchyma. Very much like less renal parenchyma can be seen in the posterior to this lesion. So it is again a case of the renal angiomyolipoma, which is usually seen in the settings of lung, and in the lung you would get to see cyst. Next is LCH. Now in LCH, you will see nodules. Previously, I discussed the nodules will be central lobular nodules, with some would be cavitating. It's basically LCH now is basically pattern, and it's a sequence, right? First, you will get to see nodules, then the nodules will cavitate, then the nodules will eventually form the cyst, right? And you will get to see very much bizarre shaped cyst, and eventually the fibrosis will also be seen, and usually seen in upper lobes, sparing of the peripheries, and also and CP angles will be seen. Strong association with smoking, and a pearl is like upper lobe, like bizarre shape cyst and smoker, so it's equals to LCH, right? Next is, again you can see multiple bizarre shape cyst in bilateral lung parenchyma. In addition to it, you can see that there are multiple centrilobular nodules. Over here you can see multiple nodules, and in addition to it you are being shown some cyst formation. So here again cysts are being shown, right? Here bizarre shape cysts are being shown. So this again a bizarre shape cysts are being shown in addition to nodules, right? So this is basically LCH. Next, again bizarre shape cysts are shown with the sparing of lower lobes and the CP angles. So it is again LCH cases. These are CP angles being shown to show that these are cysts are not in the periphery, as or in the lower lobes. Next is Birt-Hogg-Dube syndrome, right? And Birt-Hogg-Dube syndrome, you will see basal cyst in the subpleural location, sometimes paramediastinal shape cyst, and usually variable size associated with renal tumors and pneumothorax, right? And basal cyst, if seen, right, if the seen and with some lesion in the kidneys, then the differential could be Birt-Hogg-Dube syndrome. But it's like its name is very lengthy, so the abbreviation BHD is usually used. I'll be using BHD more in my in the case discussions in the coming slides. So BHD is always equivalent to Birt-Hogg-Dube syndrome because it's an abbreviation. So please remember it. Basal cyst, subpleural distribution of the cyst, paramediastinal cyst, variable size, and associated with pneumothorax and renal tumors. Now here you can see that the cyst can be seen, and they are paramediastinal, right? And these cysts can be, if the paramediastinal cysts are being shown, they could mimic emphysema. So over here you can see that there are multiple attenuated lesion, bilateral lung parenchyma in the periphery can also be seen. So these are not cysts. In fact, this is central lobular emphysema, and it's paraseptal emphysema. So it is a great big mimicker of these cysts, BHG cysts, because of the paramediastinal location. So subtle pneumothorax can be appreciated, and again the lentiform shaped cysts can be seen, again seen in BHD. Again, lentiform shaped cysts seen in BHD. So the cysts are usually seen, previously discussed, and basal and subpleural and paramediastinal. And here you can see paramediastinal basal cysts, and these are again basal cysts and paramediastinal cysts. So this is a BHD. Again, this is a pneumothorax and paramediastinal cyst, and also bizarre, not bizarre, in fact, lentiform shaped cysts. Bizarre shaped cysts are usually seen and previously discussed that in LCH. So again, you can see that this is a cyst, and like cyst usually seen in the BHD. So it is again paramediastinal cyst. It is again, and this cyst is usually seen again adjacent to the fissure. So this is again a lentiform shaped cyst. Next is a lip, right? Lip is in which you will see thin wall cyst, but a ground glass opacity will be seen adjacent to this cyst. Sometimes nodules can also be seen. Strong association with Sjogren syndrome, autoimmune disease, and HIV. So these are things we need to remember: Sjogren syndrome, HIV, and autoimmune diseases, right? And lip cysts are usually thin wall, ground glass opacity, and nodules, right? And cyst, ground glass opacities, and as always think about lip. So over here you can see definite ground glass opacity with addition to a cyst, and so this is a probable case of lip. And sometimes nodules can also be seen. So here you can see that nodules are seen. This is again a nodule, right? This is cyst, and it's a nodule. This is cyst, and here you can see ground glass opacity, addition to cyst, and again diffuse ground glass opacity with cyst formation. So it is a very case of lip. Next is dip. Dip is more like lip. However, in dip, you will see thin wall cyst with the ground glass opacity and with the subtle fibrosis. You will be showing some kind of fraction bronchiectasis and strong association with smoking. Symmetrical cysts with the ground glass with the predominance basally and predominant periphery, and they are often shown with the fibrosis. So here you can see cysts are seen bilateral lung parenchyma in the bases, and subtle fibrosis reticulation can be seen. Again, and here you can be shown the bronchiectasis with the formation of multiple cysts. This is a cyst. Bronchiectasis can be seen. So it is a case of dip. You would be given the history of smoking. Again, this is a smoker in which you can see multiple cysts with the crown glass opacities. And yeah, so this is again the case of NADIP, keeping in view the history of the patient. If the cyst in smoker are in upper lobes, if it's LCH and bizarre shaped cyst, indefinite cyst and the lower lobe with strong association of smoking and subtle fibrosis, then this is a DIP, right? And LAM, if we discuss the diffuse cyst in bilateral lung parenchyma, you won't get to see nodules or opacities, right? And however, in lip, we discuss the nodules with ground glass opacity would be seen lip, and in dip again ground glass opacity is seen, but the association is with the smoking, right? So this is again a table in which you can see that lip is diffuse distribution. Dip is also diffuse distribution, but with strong association of the smoking, and lip has dip smoking and lip has Sjogren syndrome association, or and BHD has basal cyst, LCH has upper lobe cyst, LAM has diffuse cyst, and BHD and DIP has basal cyst, right? LCH has upper lobe cyst, and LAM has diffuse cyst, and LIP has also diffuse cyst, right? LIP and LAM have diffuse cyst. Please remember it. And LAM is usually seen in females, LCH smoker, renal tumors association for BHD, and LIP is Sjogren syndrome. This is a table in which you have to remember that how we go about this if we get to see any cyst. What would be should be the step we should be follow you should follow. First, you have to classify if it's a true cyst or not, right? By looking at the margins and looking for if there is some opacity within the cyst, so it's probably emphysema. Look for the size. If it's large in size, it's probably a bulla. If it's a nematocele, like it's seen adjacent to consolidation, right? Honeycombing cells are very much distinct. You must remember it from previous case. And some other less likely differentials are bronchogenesis, CCAM, sequestration, cavitary lesions, infection, vasculitis, and septic emboli. You have to memorize all these things, right? So they are again a great mimicker. Now, next is you have to, if you are sure that these are cysts, then go for the next step and classify that if the cysts are like less than 4 or more than 4. If they're less than 4 and in above 40 patient, age of 40 patient, then ignore those cysts. But if the cysts are in more than number and in patient of less than 40, then make up the differential by looking at the nodules. Nodules, yes, it's LCH. If ground glass is, then lip. And if no nodules, then it's lamp. Less likely differentials are these, which you need to remember. By please take a screenshot. It will be very much helpful. I took most of images from an article. I'll be sharing the link of the article if you want to know. So it's a radiology assistant article. You can go through the article. It's a very much helpful. And so keep whenever you get to come across HRCT, open up that article and go to that disease which is being shared in the article. It basically gives the most of the your answers, right? Next, we are done with the cyst, right? Next is emphysema. Emphysema is basically permanent enlargement of the airspace due to alveolar destruction, not seen in the fibrosis, and the pole is no wall, right? No wall will be seen in emphysema. Now there are different types of emphysema. Central lobular emphysema, in which this previously we discussed the secondary lobular unit, right? Hexagonal structure, and this emphysema is basically in the center. It won't be involving the whole small secondary lobular unit. And seen in upper lobe, secondary lobular lucencies will be seen. No visible wall will be seen. Obviously, a strong association with this smoking, and you must report on the severity and distribution always, right? Next is panlobular emphysema. Panlobular emphysema is basically emphysema in which you will get to see lower attenuation lesions in dilated lung parenchyma. However, these emphysema will not be in the center of this secondary lobular unit. In fact, the whole secondary lobular unit will be involved, so its size will get larger, right? And it is usually seen in lower lobes and a strong association with alpha-1 antitrypsin deficiency, and usually seen in young patients, lower lobes. Central lobular was seen in smoking, upper lobe. This is in lower lobes, young patients. It's alpha-1 antitrypsin deficiency. Paraseptal emphysema is usually seen adjacent to subpleural location, and bulla can also be seen and usually seen in the single layer, right? Complications are pneumothorax, very much common in this paraseptal emphysema, and usually again seen with the smoker with the pneumothorax. So there is paraseptal emphysema. Now this is again, this one is the emphysema. However, you must remember that in the previous slide we saw this case. Here, this is central lobular emphysema, there is paraseptal emphysema, but this is not emphysema. In fact, it was a case of BHD in which you were being shown paramediastinal cyst. And this is a cyst against being shown, which is shown in the adjacent to the fissure or pleura. And this is again the paraseptal emphysema, right? This is central lobular emphysema. Now, while reporting emphysema, you must mention the grade, stage, if it's mild, moderate, or severe. It's very much important to mention the emphysema. It would be even very much helpful for the clinician, and would be but like if they go for the BFTs on those patients. So your report would be very much helpful for those clinicians. Next are the complications. Emphysema can lead to bulla formation, right? They are basically the large, low attenuation structures. Could lead to pneumothorax formation, pulmonary arterial hypertension, and combined pulmonary arterial hypertension with pulmonary fibrosis. Bronchiectasis is next is bronchiectasis, in which you will get to see bronchial dilatation, permanent dilatation, and there are certain normally the bronchi tapers down and it moves toward the periphery, but in bronchiectasis you will see that the bronchi won't taper down. In fact, it will be large in size. You won't get to see the tapering in 1 centimeter from the pleura. No, in the 1 centimeter from the pleura, you won't going to see the bronchi till that region, right? Usually tapers mid between the lung, right, in the central location. But in bronchiectasis, you will see non-tapering, and the bronchi will be large in size, and Now let's discuss the cylindrical. Cylindrical bronchitis is very much common. Like you will get to see straight branching the bronchi, dilated bronchi. However, varicose bronchitis is in this you will see the beaded appearance of the bronchi, and here you will get to see cystic for cyst formation, like cystic dilatation of the bronchi, right? So now first discuss this cylindrical bronchiectasis, in which you can see that this is bronchiectasis, which is usually large and right with bronchial wall thickening also seen and giving a tram track sign. This is a tram track sign typical for cylindrical bronchiectasis, and usually it's mild type, and the most severe is like cystic bronchiectasis, right? Next is varicose bronchiectasis, in which you can being shown beaded appearance and irregular lumen of the bronchi. Previously, you must remember that its lumen is very much irregular. However, it's irregular beaded appearance, and it is intermediate severity. And this is cystic bronchiectasis, in which you can see that there are multiple clustered cyst formation, like cyst type structures. So it is basically, it would be communicating. So it's not a cyst. In fact, it's a bronchiectasis and cystic type. And with sometimes air fluid levels can also be seen, and marked dilatation is very much severe disease, right? Um, Now, the classical signs which we previously discussed, tram tech seen in cylindrical bronchiectasis, finger and glove mucus plugging, ABPA, cluster of grapes, cystic bronchiectasis. What is finger and glove? Like mucus plug, mucus plug is being like stuck in the bronchi, and it would get dilated, and it is usually seen in the settings of allergic bronchopulmonary aspergillosis, right? So the cause of the bronchiectasis is usually the sometimes the infection, sometimes the history of the patient autoimmune, or sometimes cystic fibrosis association. If it's upper lobe bronchiectasis, probably is a TB or cystic fibrosis. If it's central, it's ABPA, right? And if it's lower lobe, then it's aspiration related, right? And if it's diffuse, then it's the immunodeficiency or PCD. Lower lobe, you must remember it lower lobe in aspiration, central ABPA, and upper lobe in TB and CF. Now, you need to differentiate traction bronchiectasis from primary bronchiectasis. Traction bronchiectasis we previously discussed was usually seen in the setting of fibrosis and interstitial lung diseases, like all those previously were discussed, the honeycombing UIP, right? The basically the architecture of the lung will be destroyed, and it will pull the trachea towards it, right? It will, oh, sorry, bronchi towards it. So the architecture of the destruction will be distorted, right? So the bronchi will be dilated. So it is basically a traction bronchiectasis seen adjacent to fibrosis. But in normally bronchiectasis, normal lung will be seen adjacent to it, and no fibrosis will be seen in the background of those patients in the primary bronchiectasis. Next is the reporting template, which you need to follow while reporting all those low attenuation structures. Like you need to comment on the pattern, what kind of pattern you're being shown. You need next you have to look for the distribution: upper lobe, mid lobe, lower lobe, periphery, basis, or submediastinal, peripheral. Look for the ancillary findings, correlate with the history of the patient, right? Ancillary finding all those joints of tissues, fusion, lymph nodes, all those things, right? Esophagus dilatation. Next, make a view diagnosis and always give the differentials if you have overlap of the findings, right? Now, this is again the reporting checklist of all those disease which previously discussed in detail. Ground glass opacities, you have to comment on very much important nodules, reticulations, honeycombing, bronchiectasis, emphysema, pleural thickening, pleura. You have to comment if there is any pleural effusion, right? And mediastinum, you have to comment on the mediastinum, look for any lymph nodes, any fibrosis, plural, look for plural technique, effusion, emphysema, all type bronchiectasis, all type honeycombing, reticulation, spine, plume, fine or coarse, you have to comment on, right? Nodule formation, you have to comment on. Ground glass opacity is very much important. So the common mistake we now like I'm winding up the lecture. So you have completed all those things and you have in detail, and so please avoid these common mistakes by overcalling the emphysema as a cyst. Cyst has a wall, emphysema has no wall. Don't overcall honeycombing. You know the difference of the honeycombing. Don't never miss air trapping. Never ignore the distribution pattern, and always like give the differential if you are not sure, right? Don't just come to a some single disease, right? And so these I have shared the template with you for the HRCT reporting. I hope it will help you a lot. That's all from my side. I'll be giving you further case discussions. Whenever I get to come across very interesting case, I'll be sharing the video with the reporting of from my end into the group so that you keep on learning along with me regarding the HRCT. And if you have any questions, please let me know. I'm happy to answer. So that's it for today from my side. And thank you so much for joining in, and stay tuned for the future course, right? And yeah, thank you and bye bye.